Which of the following is considered a classic respiratory indication for initiating venovenous (VV) ECMO in an adult with ARDS? A. PAO2/VO2 less than 150 for 24 hours. B. PAO2/VO2 less than 80 for greater than 6 hours despite optimization. C. pH of 7.30 with PaCO2 of 50 mm of mercury. D. Failure of a single trial of prone positioning for 1 hour. Answer: B. PAO2/VO2 less than 80 for greater than 6 hours despite optimization. Explanation: according to ELSO guidelines and the EOLIA trial criteria, a P/F ratio less than 80 mm of mercury for more than 6 hours, or less than 50 for 3 hours, despite optimized ventilator settings, including PEEP and neuromuscular blockade, is a standard threshold. In veno-arterial (VA) ECMO selection, which parameter is the primary indicator for support? A. Isolated hypercapnic respiratory failure. B. Cardiogenic shock with a cardiac index less than 2.0 liters per minute per square meter despite inotropes. C. Correctable hypovolemic shock. D. Persistent SVT with stable blood pressure. Answer: B. Cardiogenic shock with a cardiac index less than 2.0 liters per minute per square meter despite inotropes. Explanation: VA ECMO provides circulatory support. It is indicated when there is profound cardiogenic shock, low cardiac index, high filling pressures, and signs of end-organ hypoperfusion, that is refractory to conventional medical management. Which of the following is generally considered an absolute contraindication for ECMO? A. Age greater than 65 years. B. Mechanical ventilation greater than 3 days. C. Unrecoverable brain injury or intracranial hemorrhage. D. BMI greater than 40. Answer: C. Unrecoverable brain injury or intracranial hemorrhage. Explanation: ECMO requires systemic anticoagulation. A non-survivable CNS injury or an active, uncontrollable brain bleed makes ECMO futile and dangerous. Age and BMI are usually relative contraindications. A 45-year-old male has been on high-pressure mechanical ventilation for 12 days. Why is he likely a poor candidate for VV ECMO? A. High risk of circuit thrombosis. B. High likelihood of irreversible pulmonary fibrosis. C. Inevitable development of VAP. D. ECMO is contraindicated in all males over 40. Answer: B. High likelihood of irreversible pulmonary fibrosis. Explanation: prolonged mechanical ventilation, typically greater than 7 to 10 days. At high settings is a strong relative contraindication because the lungs may have already transitioned to a fibrotic, irreversible stage where ECMO cannot bridge them to recovery. What is the significance of the PRESERVE score in ECMO selection? A. It predicts the risk of bleeding during cannulation. B. It calculates the flow rate needed for the pump. C. It predicts mortality in patients post-VV ECMO for ARDS. D. It determines the size of the drainage cannula. Answer: C. It predicts mortality in patients post-VV ECMO for ARDS. Explanation: the PRESERVE score, predicting systemic inflammation and organ failure, helps clinicians estimate the probability of survival 6 months after VV ECMO, aiding in the selection of patients most likely to benefit. Which condition is a contraindication for VA ECMO specifically? A. Severe aortic regurgitation. B. Acute myocardial infarction. C. Fulminant myocarditis. D. Postcardiotomy shock. Answer: A. Severe aortic regurgitation. Explanation: severe aortic regurgitation is a contraindication for VA ECMO because the retrograde flow from the ECMO cannula into the aorta will worsen the regurgitation, distending the left ventricle and causing pulmonary edema. In pediatric ECMO selection, which gestational age is typically the minimum cutoff to avoid intracranial hemorrhage? A. 24 weeks. B. 28 weeks. C. 34 weeks. D. 40 weeks. Answer: C. 34 weeks. Explanation: Neonates less than 34 weeks gestation are at a very high risk of germinal matrix hemorrhage when heparinized for ECMO. Therefore, 34 weeks is generally the lower limit. Which of these bridge strategies is a valid indication for ECMO? A. Bridge to nowhere, unknown diagnosis. B. Bridge to heart or lung transplantation. C. Bridge to a DNR, do not resuscitate, order. D. Bridge to chronic bed rest. Answer: B. Bridge to heart or lung transplantation. Explanation: ECMO is most ethically and clinically sound when used as a bridge to recovery, bridge to bridge, VAD, or bridge to transplant. A bridge to nowhere, no exit strategy, is avoided. Why is advanced malignancy with poor prognosis a relative contraindication for ECMO? A. Cancer cells clog the oxygenator. B. Survival is limited by the primary disease, not the acute failure. C. Chemotherapy reacts with the ECMO tubing. D. Cancer patients never have respiratory failure. Answer: B. Survival is limited by the primary disease, not the acute failure. Explanation: ECMO is a resource-intensive rescue therapy. If a patient's underlying malignancy is terminal or has a very poor short-term prognosis, the risks and costs of ECMO usually outweigh the potential benefits. What is the Murray score used for in the context of ECMO? A. Assessing neurological status. B. Quantifying the severity of lung injury. C. Measuring cardiac output. D. Predicting renal failure. Answer: B. Quantifying the severity of lung injury. Explanation: the Murray score, lung injury score, looks at PAO2/VO2, PEEP, lung compliance, and the number of quadrants with infiltrates on CXR. A score greater than 3.0 is often used as a threshold for considering ECMO.